thank you, Professor DeFronzo, for taking the time to speak with us about your interesting research. You just had a perfect talk about the results of the CATALYST trial. Could you summarize the key points of your findings?
Yeah, this has been pretty exciting here. This is, I think, it's actually an old story. It's been around for a long, long time, but not appreciated. So the original studies actually were done here in Europe, in France, and Italy, and it had been known by investigators in Europe that if you look at people with difficult to control diabetes, meaning their A1C is markedly elevated despite 2-3 medications, they can't control them. And the investigators started to look and say, well, maybe hypercortisolism is playing a problem here. And there are actually several nice publications in the literature showing that if you look at this difficult to control population, a lot of them have hypercortisolism. So that actually is what has led to the CATALYST study. So in the CATALYST study, what we wanted to know is what is the prevalence of hypercortisolism as a factor explaining why you might have patients with diabetes who are difficult to control. So we enrolled about 1,000 patients, and what we showed is that the prevalence of hypercortisolism in this difficult to control diabetic population was about 24%, 23.8%, 24%. So if you were to extrapolate this to the difficult to control population in the United States, that's about 1.2 to 1.4 million people. So this is actually a large number of people. I run the Texas Diabetes Institute. We see about 10,000 unduplicated patients per year. And I have to say, we were one of the sites, and in the first 33 patients that we screened, 18 of them, 40% of the people turned out to have hypercortisolism, and very dramatic responses to inhibiting the glucocorticoid receptor with a drug called mifepristone. So based on this very large now U.S. study, the results in these 32 sites were very consistent. It didn't make any difference whether you were in Texas, where I live, or you were in Boston or in California. Difficult to control diabetes, when we looked at them, a lot of these people had underlying hypercortisolism. And of these people who have hypercortisolism, about 1/3 of them had adrenal adenomas. So in this group, basically, if you take out the adenoma, you have the best treatment in the world. Drug treatment with the mifepristone, which is a glucocorticoid receptor antagonist, was also very effective, but you'd have to maintain on the drug. If you have an adenoma, then the surgeon will go in and remove the adenoma. So for the adenomas, we have a correctable. The importance of recognizing early, however, and I showed these data today, cortisol has very deleterious effects on the cardiovascular system. So if the disease goes unrecognized, a lot of people get atherosclerotic cardiovascular disease, myocardial infarction, heart failure was increased threefold, atrial fibrillation. So the earlier you make the diagnosis, well, you control the glucose, that prevents the eye, the kidney, and the nerve problems, but it also is helping you in terms of the cardiovascular protection. And believe it or not, we have a drug that's already approved by the FDA to treat hyperglycemia in people with Cushing's disease. But this was approved a long time ago for florid Cushing's. No one thought that we were going to have this very common sort of subclinical hypercortisolism.
Yeah, perfect. You said in your talk a new disease with an old drug. Can you elaborate on that? What do you wish for the future, for the treatment, for the clinical treatment?
Yeah, so we have, I would say, an old disease. As I said, Harvey Cushing's described classic Cushing's in 1932. You know, and the lady is in every textbook. It's mini G. She has puffy face, stria, etc. And so it's an old disease. Okay, it's not a new disease. The new disease doesn't look like the classic Cushing's. They look like any patient in your diabetes clinic. So it's been unrecognized, and now we have a new drug. to treat an old disease. And the new drug is actually quite effective.
And what are the next steps in your research? What do you want to do?
Yeah, so I am interested from two standpoints, okay? One standpoint is I'm particularly interested in sort of the molecular biochemical mechanisms of why does hypercortisolism cause all of these metabolic problems? Why does it cause cardiovascular disease? So my interest is, number one, scientifically, and the second interest, of course, is from a clinical standpoint. We need to educate physicians that they understand if you have someone who's on 2 or 3 oral agents. One of the drugs that showed up all the time was tirzepatide. This is a phenomenal drug. If I put you on tirzepatide, there's no reason why you shouldn't respond to this drug. So if you're treating someone with tirzepatide, which is Mounjaro, or Ozempic, which is sitagliptin, one of these newer drugs, and the patient's not responding, you really ought to be thinking about why. And a lot of these people are going to turn out to have hypercortisolism, and we have a drug, Korlym, mifepristone, which is available for treatment. And there's a new generation of the drug that's being developed. It's called relacorilant, which has actually even fewer side effects than does the mifepristone. So education is something that's important. And then the better that we understand the pathophysiology, maybe we can come up with even better drugs that have fewer side effects.
Perfect. Thank you. It was very interesting, and we wish you a nice conference this next days.
Okay. Thank you. I'm glad I got to chat with you.